It's hard to have the discussion about trachs and vents, especially if the patient knows that the family doesn't want the same thing that they do, or vice versa. So, bringing it up at your clinic visit is one of the best things that I can recommend, because the clinic team can help facilitate that discussion. I personally would be happy to assist patients when they came to my clinic in that discussion. So, asking one of your clinic members to maybe be present during that, whether it's the nurse or the social worker, or maybe even the doctor if he chooses to do that. But having another person there that can maybe provide some education for your family members that might not know everything about it, or may need a little more education in what's actually involved in the procedure or the aftercare or things like that, to help get the discussion going. But anything that the patient needs to help make that communication happen is what the clinic team needs to do for the patient. The clinic team's going to know what your respiratory status is based on your numbers and give you an idea of what your options really are. They're going to know home health care facilities in your area, nursing facilities in your area. If you want to go home, is a facility even available that has vent trained nurses for you to go home? We certainly wouldn't want you to want that option, and then the closest vent trained home care agency is 3 hours away, and you didn't know that. You have to look at all of those options when making that decision. So bringing your clinic team into making that decision is something that you should consider. Another consideration is a feeding tube. If a patient does not have a feeding tube, we're going to put one in because they won't be eating by mouth anymore. So a feeding tube will be not an option at the point where they choose mechanical ventilation. That will be placed as well. The other thing that is a big problem with patients that they don't take into consideration is the fact that they cannot speak with a trach. Some people can speak with a trach. ALS patients are different. The reason why is how we speak is we are moving air through our vocal cords, and that stimulates the sound. Tracheostomy goes below the vocal cords. So in order for me to get air through my vocal cords, I have to close off that trach so that the air can go up and out. If I close this off, I'm not breathing as an ALS patient. So they always have to be attached for air. It's never going to go up through the vocal cords. So highly unlikely that a patient is going to talk again with a vent. So we have to make sure that they have alternate means of communication. If they were speaking before, they have to be able to use something else. Now, after all of those decisions are made and the patient still wants mechanical ventilation, the other question that I ask them is, when do you want shut off? Very hard thing to consider, but the disease is still progressing, and at some point in time that patient may be unable to move at all, unable to communicate, unable to do anything, and they will decide that that quality of life is no longer for them. They probably will not be able to communicate that need at that time. So I want that in their advance directives before they're making the decision for mechanical ventilation. I want that written down, that if this, whatever it is, if this happens, this is when I want my family to remove me from mechanical ventilation. And when that happens, then we bring hospice in. And it is not a shutting off the machine. It is a weaning down process. The patient is medicated. It's very peaceful. There's no pain involved. But we want to make sure that everybody on board knows ahead of time that this is what's going to happen. And so that the patient has already made that decision, so the family doesn't have to make that difficult decision when the time comes. You know, would dad want to be taken off of mechanical ventilation or not? I don't know. Lots of families deal with that struggle of guilt. And if the patient can do that ahead of time in their advance directives, then that removes all of that guilt from the family. The family knows when dad wanted it to be done, and everybody's on board with the decision well in advance. It's already been talked about, and then there are no issues with that at the time of death. It's a very peaceful procedure. Everybody's comfortable with it. The family knows, the patient's made the decision, and it's the way that it should be as far as I'm concerned.